Good afternoon, everyone. This is Robin Molding, and I'd like to welcome you to our webinar, The Intersection of Housing Policy and Health. And now I'd like to introduce our moderator, Jill Kaduri. Jill?
Thank you, Robin. My name is Jill Kaduri, and I am a Principal Associate in the Housing Practice here at Abt Associates. Welcome to this webinar on the intersection of housing policy and health. We are coming at the issue of how to implement the Olmstead mandate from two directions. One is how to provide community-based housing for people with disabilities. The other is how to give people with disabilities who live in community settings the medical and related support that they need. We have with us today in this webinar some of the nation's leading experts and practitioners with experience on how to put housing and healthcare together. We have had a tremendous response with several hundred people registered today. Now I'd like to turn this over to my colleague Donna Mosh, who is a Principal Associate in the U.S. Health Division at Abt Associates. She will introduce the first panel. Donna?
Thank you very much. This is Donna Mosh. I appreciate your introduction, Jill, and welcome again to everybody. I'm delighted to introduce the speakers to the first panel who are going to address the alignment between national disability policy and financing provisions that are now available to us both through the Affordable Care Act and other housing provisions. We're going to focus in this first panel on options available through the Affordable Care Act to implement Olmstead. I'm going to introduce both speakers and then turn this over to the first speaker and in turn move it to the second speaker. So our speakers today are Allison Barkoff and Chuck Milligan. Allison Barkoff is a Special Counsel for Olmstead Enforcement in the Civil Rights Division of the U.S. Department of Justice. In that capacity, she leads the division's efforts to enforce the rights of individuals with disabilities to live, work, and receive services in the community under the ADA and other civil rights statutes. The department's been actively involved in Olmstead matters across the country, and in several cases, the work has culminated in statewide system reform settlement agreements. Ms. Barkoff is also on detail at the present time to the Centers for Medicare and Medicaid Services at HHS, where she's working on home and community-based services regulations, as well as policy regarding supported employment and community housing. She also works with the Department of Labor and HHS on implementing new home care regulations and state Medicaid systems. And prior to joining the government, she was at the Bazelon Center for Mental Health Law and several other private firms, again addressing litigation and policy regarding community integration, healthcare, housing, and special education. She's published a number of articles and spoken nationally on a range of issues, including the one she'll be speaking on today. Our second speaker is Chuck Milligan. Chuck Milligan was appointed as Deputy Secretary for Healthcare Financing at the Maryland Department of Health and Mental Hygiene back in March of 2011. In this role, among many other things, he's responsible for the state's Medicaid program. Previously, Mr. Milligan was Executive Director of the Hilltop Institute at the University of Maryland in Baltimore County. This is a research center that provides services to the Maryland Medicaid program as well as other state and local agencies, the federal government, and private foundations. Earlier in his career, he was the Medicaid Director for the state of New Mexico. He holds a JD from Harvard Law School and an MPH from the University of California at Berkeley, as well as a BBA from the University of Notre Dame. So welcome, Allison and Chuck. And Allison, I'd like to turn this over to you.
Okay. Good afternoon, everybody. Can everyone hear me? Okay. So I'm going to focus today on Olmstead and really give a little bit of the legal overview and talk about the ADA work the Department of Justice has been doing, and then touch on some of the Medicaid authorities and ACA, and I know that Chuck is going to talk about those in more detail. So first talking about the ADA and Olmstead. So the ADA is a civil rights statute that protects people with disabilities, and Title II of the ADA prohibits discrimination against people with disabilities by public entities in all of its services, programs, and activities. And the Olmstead Supreme Court decision and Title II has made clear that it violates Title II of the ADA for people to be unnecessarily segregated or placed at serious risk of being segregated by state programs. The integration regulation requires states and public authorities to administer services, programs, and activities in the most integrated setting appropriate, and that's defined as a setting that enables people with disabilities to interact with people without disabilities. And again, just to make sure everybody understands the scope of the ADA, it's not only applicable when the state directly operates services, it applies whenever a state funds and designs services. So if a state operated private facilities, it's equally applicable. And as I mentioned, it's not only people who are in segregated settings, but those who are at risk of entering those. As we're starting to talk about housing issues, again, through the ADA, the lens talks about integrated settings. And the Department of Justice has talked about those as places that give people with disabilities the opportunities to live, work, and receive services in the greater community. And so factors that the Department of Justice looks at, that the courts have looked at, is whether the setting is located in mainstream society, whether it offers access to community activities, and whether people have choices about those activities and with whom they do those activities. People have a choice in the daily life activities we all take for granted, when to eat, when to go to bed. And again, the ability to interact with people without disabilities to the fullest extent possible. I just want to note for people that CMS has recently, just in the last 2 weeks, issued regulations defining for their community-based programs what a community-based setting has to be. And these are very similar types of characteristics. And while Medicaid and the ADA are not one and the same, they certainly align around supporting each other and making sure people do have opportunities for real integration. Both the Department of Justice as well as private advocates have really been using the ADA as a tool for system change and for large system change, often on a statewide basis, and systemic reform activities. Sometimes this has been done through litigation that leads to settlement agreements, and other times it's done through voluntary Olmstead planning at the state level. I know a number of states have been incredibly active in bringing together all of the different state-level players, whether it's each of the operational departments, BD and mental health and aging, as well as bringing together housing and school systems to kind of look broadly at a plan and engage a range of stakeholders. And the types of activities that are coming out of this Olmstead planning or these settlements are increasing the capacity of community services that are critical for successful community tenure. And I'm going to talk in a minute about what some of those key services are. Certainly, any of us who have been doing community integration work realize that that without access to affordable housing in the community, people can't be successful, and so expanding the supply of integrated community housing available to people with disabilities. Again, increasing the investment in community services and housing is incredibly important and has been something that people have been pushing for. But in addition to new monies, part of the activities have been to better leverage existing disability service and housing funding streams, and I'll touch on some of those strategies a little later in my presentation. So in terms of the Department of Justice settlements, I just want to talk about some of the critical community services that we've been looking at. And I would encourage people who are interested to go to the Department of Justice's website, and I have that on a slide at the end. You can look at each of our settlement agreements, and we've been trying to create national models for what are the critical community services that a behavioral health system should have in place, that a developmental disability system should have in place, that a physical disability system should have in place. And just to touch on those, our agreements have expanded these critical services, sometimes through rebalancing strategies. The states have downsized institutional settings and reinvested that money into the community, or again, better leveraging Medicaid. And so things like home and community-based service waivers and expanding the number of waivers available, making sure there's a range of crisis services available, everything from mobile crisis teams to walk-in centers, hotlines, crisis stabilization programs. On the mental health side, assertive community treatment, intensive case management. Again, I want to emphasize that Olmstead is not only about where you live, but how you spend your days, and we've done an incredible amount of work ensuring that there are supported employment opportunities and integrated day activities, and finally, family support. On the housing side, we've also been looking at expanding housing opportunities and making sure that those are integrated. And so some of the characteristics of the supportive housing that the Department of Justice has really been looking for an expansion of. Again, it's not about taking community housing offline. It's about, as states are expanding new housing opportunities, what should they look like? And some of the characteristics are housing first, so ensuring that a range of flexible services and supports are available, but they're not mandated as a condition of tenancy, that this is permanent, not transitional housing, that people who live in these settings have the rights and responsibilities of tenants, that the housing is affordable, and we've primarily been focusing on integrated, scattered site housing, so non-disability specific housing, similar to the kind of housing that is now being focused on under the new 811 program, and ensuring that people have a choice of a housing unit, whether they want to have a roommate, and if they have a roommate, who that is. In addition to supportive housing, we've been also looking at expanding other housing models depending on the disability population. So sometimes, and more common in the developmental disability system, is supporting someone to live in their family home. And family homes are critical. Supported apartments where staff may be on site, host homes, sometimes called adult foster care, or very small group homes. Again, I just want to briefly touch on some Medicaid opportunities for Olmstead activities, because a piece of Olmstead is this fundamental alteration defense that looks at what resources does the state have available. So again, the law doesn't say anytime there is more expenditures, the state doesn't have to do it. On the other hand, I think we all have been sensitive to how do we best leverage the money that's out there. So some different funding strategies are rebalancing institutional funding to expand community services and housing. The Money Follows the Person program has been incredibly important to that, and the Affordable Care Act expanded that, and that program allows states and has enhanced funding for states to transition people from qualified institutions to the community. The Balancing Incentive Program, which gives enhanced FMAP to states for rebalancing their larger system from one that's heavily reliant on institutional care to community care. Other strategies on the mental health side include providing mental health services in the community where Medicaid can be leveraged, rather than providing them in institutions where generally state dollars have to be used exclusively, and taking state cost savings from institutional downsizing and reinvesting in expanding community services, and or using those state dollars to create rental subsidy programs to bridge to mainstream affordable housing programs. Some other Medicaid opportunities through ACA. Obviously, the Medicaid expansion is important, and it's particularly important for people with mental health needs who may not have been eligible for Medicaid before. The new 1915K, Community First Choice, provides for community-based attendant care, and an enhanced FMAP has been really important in terms of helping keep people in the community. There have been improvements to the 1915I, which was an authority that was created in 2005 and allows states to offer a broad range of community services pretty similar to the 1915C, but doesn't require the same level of institutional care. So hopefully the 1915I will be a really good strategy for expanding services in particular to people with mental health needs who weren't able to meet the 1915C standards before. And health homes are another important thing created by ACA, which is an optional state plan around coordinating care for people with chronic conditions. And again, there's an enhanced FMAP there. Finally, I will touch on the new home and community-based regulations, and I'd encourage people to look at those. I think those are a really important tool as states are looking at complying with Olmstead, as they're looking at what's offered in their home and community-based programs, and I think it's an important tool for advocates. I think that this will be a game changer in some states, and it will really force state programs to look really closely at ensuring that any types of settings, both residential and non-residential, in their community-based programs offer people opportunities for real integration. And finally, just a little more information. The Department of Justice website at ada.gov/Olmstead has a wealth of information. It has detailed Olmstead guidance, answering a Q&A about really common questions. We have all of our settlement agreements, our findings letters, briefs, guidance, and testimony available there. In terms of CMS and the new regulations, Medicaid.gov/HCBS, and you can link directly to the regulation as well as a series of fact sheets. And information about webinars. I'd encourage people, there are webinars that happen this week and next week that are open to the public to learn all about these regulations. And for more information about ACA, I've also put the Medicaid.gov website. And with that, I will turn it back over.
Allison, thank you so much for that presentation. Without any delay, I'd like to turn this over to Chuck for his presentation, after which we may have a couple of questions. Chuck?
Hello, everybody. I'm going to talk through some of the options that Maryland has adopted under the Affordable Care Act, and this is a little bit of a menu of what we're doing, and I'll touch on some of those programs. And there's lots more to talk about each of these if people have interest in terms of some of the complexities of launching these and how we work through those. So this slide is just a preview slide of the 6 points I'm going to be talking about. One is Money Follows the Person, the Balancing Incentive Program that Allison just mentioned, as well as the Community First Choice Program. We did merge 2 of our home and community-based waivers effective January 1st. I'll talk about ISAS, and I'll define that term when I get to that slide. And the other part in terms of rebalancing that often gets lost in these conversations is what states can do to simplify and streamline the Medicaid eligibility determination process to help accelerate somebody into community-based services. So let me just talk about Money Follows the Person first. Maryland's been doing it for a while. As Allison mentioned, it's a relatively new program dating back not quite 10 years ago, and then improved in the ACA. In Maryland, we've assisted over 1,800 people who transitioned from nursing facilities into the community since the launch of the program. For each of these conversions, we get an enhanced federal Medicaid match. It's time limited, but we get money to help with the transition. We have been able to pay for peer outreach and supports for some of the options counseling in nursing facilities. So this is to help people while they're in a facility to learn about community-based alternatives to help with the discharge part of that. And we built a tracking system that has been very helpful to us to load everybody's plans of care, everybody's needs, in a way that case managers, families, and others can have some visibility into what the person should be receiving, and make it also a system that is adaptable as needs and status changes over time. The major barrier we're seeing in terms of helping more people move out of nursing facilities into the community is affordable housing. A lot of the individuals have limited incomes, they're on SSI or have other limited means, which is part of the reason they're on Medicaid. Under SSI, people cannot use their Medicaid can't pay for, let me back up a second, in general and unrelated to the eligibility group, Medicaid cannot pay for food, clothing, or shelter in the community. So Medicaid is barred from helping to directly subsidize housing, and for people of limited means and people on SSI and otherwise, they can't afford often the housing, and what keeps them stuck in nursing facilities is the fact that we can neither pay for housing in the community nor can they afford it themselves. Moving on, the Balancing Incentive Program was created under the ACA. It was a competitive grant-based program. The funding runs through the end of federal fiscal year 2015, so through September 30th. We applied. We received a $106 million grant. We are able to use this grant money, the $106 million, to match against our state funding for specific community-based long-term services and supports, and get more leverage out of our state investment. To qualify for BIP, we had to make some structural changes. We had to move to a core standardized assessment instrument so that we were using the same tool across our programs, across waivers, across the nursing facility population, and have a more uniform approach to assessment. We had to improve and expand statewide our No Wrong Door single entry point, and a lot of this involves Aging and Disability Resource Centers, or ADRCs. And we had to have a conflict-free case management program. And what this means is the case manager is really a consumer advocate. They're not somebody who's really doing an authorization type function for the state. The next program I want to mention is Community First Choice. This is a program under the ACA for states to get a 6% bump in our federal Medicaid matching rate. It's largely focused on attendant care, personal care services, or other supports that substitute for those services. There is a requirement that states allow individuals in Community First Choice to have an option for self-direction, but it allows waiver-like services or home and community-based waiver-like services to be provided in our regular Medicaid state plan for people who qualify for Medicaid but are not in a waiver slot. It allows Medicaid to set consistent policy and rates across programs, and Community First Choice does depend on an institutional level of care that is meeting nursing facility level of care. I want to go back to that second bullet point, the second sub-bullet point about Medicaid setting consistent policy and rates. We had, prior to launching Community First Choice, which we did on January 1st, we had different rates for attendant care in different parts of our Medicaid program. We had one rate for our Medicaid state plan service, attendant care. We had a different rate or rates in different home and community waivers, essentially for the same service. So to use Community First Choice the way we did it, we had to have more standardization across our rates and policies, which has been helpful in terms of creating equity so that consumers in different programs weren't really competing for providers based on what rates were offered in different programs. This is the service array in Community First Choice. It is personal care, personal attendant services, supports planning and case management qualifies, other items or services that substitute for human assistance. So we can pay for environmental assessments and modifications, some technology in homes, home-delivered meals. We can pay for consumer training, for personal emergency response systems in people's homes, for transitional services out of institutions and for nurse monitoring of the medical side of plans of care and for individuals to help link their medical supports. CFC created momentum in Maryland to merge two of our home and community-based waivers, and I want to talk about this for a second. Prior to January 1st, we had what we referred to as a living at home waiver. This was targeted really for younger adults with physical disabilities. And we also had a waiver that was known as the waiver for older adults, which was targeted more for seniors. Both of these groups met nursing facility level of care, but it was two different waivers. We combined the two, and it's now called the Home and Community-Based Options Waiver. It serves all adults 18 years of age and older, and all of the current enrollees in the two previous waivers were merged into the new waiver. The waiver participants in the new waiver get a choice of case manager, case management, supports planner, and access to a larger provider pool because we merged the provider groups in these two waivers as well. And we merged the services in the two waivers because the services themselves were not quite identical or aligned in the previous waivers. So now it's a broader menu of providers, broader menu of services, and now individuals, for example, in the living at home waiver as they age, aren't going to have issues about transitioning across two different waivers. Why did CFC create this momentum? Here was our previous service structure. In our Medicaid state plan, we paid for personal assistant services and paid for case management and nurse case monitoring. In our living at home waiver, you can see the array of services we offered. It included personal emergency response and transition, home-delivered meals, assistive technology, and other things. In our waiver for older adults, it was the most extensive menu of all. Many of these services qualified for CFC, but we would not get that 6% enhanced match unless the service was moved into our state plan and became part of our Medicaid entitlement program. And so one of the reasons that CFC created momentum to merge the waivers is we had to pull a lot of services out of our waivers to maximize the federal funding opportunity in CFC. And once we did that, we ended up with essentially skinnier benefits in the waivers, the services left behind in those waivers, and the argument for keeping these two separate waivers went away, really. And in fact, in Maryland, we're going to be able to obtain $24 million a year more in federal Medicaid funds just because of that enhanced match. So this is the new service structure. In our state plan, we have, in our regular state plan, this includes people who are not nursing facility level of care. We continue to offer personal assistance services, case management, and nurse monitoring. And in this part of the state plan, and the reason it's distinguished from CFC, is that we make these services available to people who do not meet nursing facility level of care, because you have to meet nursing facility level of care to qualify for CFC. You can see in the middle column, CFC is a very broad array of services, many of which previously were in the waivers, and we can now get full the enhanced match on those. And then we have a unified waiver, which is the column on the right. You can see in the lightly shaded cells, all of the people in the waiver can continue to get the services they previously got. It's just now through the state plan in CFC, it's not through the waiver. So they did not lose those services. And then you can see in the darker blue in that waiver column the remaining waiver services for people in our new combined waiver. Changing gears, and this is not an ACA-related thing, but I did want to mention this, and this is a trend in many states about how to use technology to improve accountability and quality for the consumers getting in-home services. In Maryland, we have what we call ISAS. It stands for In-Home Support Assurance System. It's a phone-based billing system for in-home personal care providers. It was designed to simplify billing and also to monitor provision of services. The way it works is a provider, when they arrive at the participant's home, they phone in using the participant's home phone and say, I arrived. And that clocks them into our payment system, and they also phone in and when they're leaving, and that clocks them out. That creates a length of service for that visit. That creates a claim directly into our payment system based on the time elapsed at our hourly rate. We do have edits to make sure that that provider is enrolled in our program, that that participant is enrolled in our program, and that that visit was part of the participant's plan of care. The claims are automatically generated out of this system. Nobody has to submit paper claims anymore. We know the visit occurred, and then we process claims on a biweekly basis. One of the questions people might have is, what happens if the participant doesn't have a home phone? And we then expect the worker, the caregiver, the person, the attendant, to use their cell phone and call in. And how do we know that they're in the person's home? We've trained our consumers we've given them a fob that has an encrypted number that changes every few seconds. And so when the call is placed, the worker has to be looking at that fob that we've given to all of our participants and read off the number that is showing at that particular precise time to know that they called from the person's home using that encrypted fob. But there's other GPS and other types of technology to make sure that the visit happened, the amount of time was appropriate to the plan of care, and that the worker didn't just send in a paper claim without ever visiting. And we've seen great provider satisfaction because it simplifies claims, and great consumer satisfaction because it provides more assurance of the visit. This is my last slide about eligibility reforms, and I want to mention a couple of things. The first bullet is we've simplified our eligibility process in the last 18 months so that when somebody wants to get into Medicaid long-term care, whether it's in an institution like a nursing home or an HCBS waiver, we don't do all of the long-term care eligibility of the 5-year look-back period and acid test and transfer penalties and all of that if they are already known to Medicaid. If they're part of our eligibility system already, and we have a period we look back and say, was this person previously in Medicaid because of SSI or community-based Medicaid eligibility because of poverty? And this would also now include, in Maryland, all of the adults up to 138% of poverty under the expansion in the ACA, because Maryland is one of the states that did the expansion. So if somebody is known to us and now they want to get into a long-term care, long-term services and supports program, we don't require the person to go through all of the effort about long-term care eligibility and 5-year look-backs, which we have found in our data eliminates that financial eligibility paperwork, bureaucracy barrier for about 40% of the people seeking services. The second point I want to make is on the bullet below. We, in our 1115 Medicaid demonstration waiver, we allow people who are above 300% of SSI to transition into the community or to stay in one of the HCBS waivers, even if they have more income than 300% SSI, because we want to avoid the institutional bias of the way Medicaid spend-down rules work. And I want to elaborate this for a second. Usually, the financial ceiling to qualify for as a categorical person, a state can qualify for somebody up to 300% of SSI. That translates roughly to about 220% of the federal poverty level. And if somebody's income is above that, they don't qualify unless they meet what's known as spend down. Spend down means, and this is an optional eligibility program for states, spend down means your medical bills are so high that your net income is very low. And so if somebody has very big medical bills, they can qualify for Medicaid in a state that does spend down because those medical bills make essentially their net income low. In nursing facilities, the whole nursing facility charge is considered a medical bill that allow somebody to be poor for spend down eligibility purposes, because this is a gigantic bill from a nursing home. But embedded in that nursing home bill is the room and board the nursing facility charges for the residents, the residential part of nursing home care. But when that community, they can't use their rent payment or their other housing costs or their food costs as a medical expense and qualify for spend down. So we had found in Maryland that some percentage of people were staying in nursing facilities because in a facility, that big nursing home bill, they could count it as an expense, medical expense, and they would qualify for Medicaid. But if they went to the community, they would lose their Medicaid eligibility. This isn't about waivers. They would lose Medicaid altogether because their income would have been too high because they couldn't count their rent or other community-based living expenses for spend-down rules. We sought to resolve that through a waiver to have more of a level playing field, and we've got an approved waiver to do so. So I will stop there and turn it back over to the moderator.
Chuck, thank you very much for that excellent and informative presentation, and Allison as well. Clearly, the Affordable Care Act provides some critical opportunities for individuals with disability to realize the promise of the ADA and Olmstead decisions for integrated supported living in home and community-based settings, and your tips to us and sharing of practical considerations today, whether it was discussing implementation considerations or regulations to support the changes we've discussed, or financing strategies that ensure you can cover the best mix of services at the state level, or strategies for maximizing new enrollment opportunities. These have all been very helpful. I'd like to introduce my colleague Gretchen Locke now, who's going to facilitate the second panel. Gretchen is a senior associate and scientist in the SEP, or the housing practice, in our Social and Economic Policy Division at Abt. Gretchen?
Thank you, Donna. Hello, everyone, and thank you for joining us this afternoon. Again, my name is Gretchen Locke. I'm in the housing practice at Abt, and I'll be introducing and moderating our second panel today. This panel is going to address the need for coordination to bring together resources for housing and supports to ensure the successful transitions we're all looking for. We will hear about some promising tools and strategies from our speakers, who I'll briefly introduce now. Our first panelist is Kevin Martone. Kevin is currently Executive Director of the Technical Assistance Collaborative in Boston, a nonprofit consulting firm that helps government agencies and other clients on various aspects of housing and services for people with disabilities. He's also past president of the National Association of State Mental Health Program Directors, and he was Deputy Commissioner of the New Jersey Department of Human Services, where he negotiated the state's Olmstead settlement agreement. And then our second panelist will be Dan Burke. Dan is the director of the HUD Chicago Multifamily Hub. Before joining HUD, he was statewide housing coordinator for the governor of Illinois, where he implemented community-based strategies for persons transitioning from institutional care to community settings with support services. He has 25 years of experience as a developer preserving at-risk HUD-assisted housing. Thank you very much to both of you for joining us today. And Kevin, I'd like to turn it over to you to begin the presentation.
Okay, thank you, Gretchen, and hi, everybody. Some of the things that you may hear when I go through my presentation may sound a little bit duplicative or redundant from some of the previous speakers when talking about some of the financing mechanisms and things like that, but I think that's because they're that relevant to the issues of Olmstead and community integration and access to health care. So I want to briefly talk to you, really about Olmstead housing and health care at the system level, and then bringing it down a little bit more to somewhat of the direct service or operations level. And I think what I want to also reiterate, something that Allison said, is from an Olmstead perspective, I'm really referencing people who are not only coming out of institutional settings, but people who are also at risk of entering institutional settings. I've found that much of our work, whether it was when I was, working in state government in New Jersey or now at TAC, through our Community Integration Center, is always about building arguments or positions to bring together key decision makers. And I think you'll see that emphasis throughout these slides. Okay. This first slide, I think, is just an important point when you're starting to think about making these arguments. That housing is really a determinant of health. And I think generally the point being that housing plays a role in a person's health status, and a good healthcare strategy includes access to good, safe, decent, affordable housing. And I think that's just a key concept to keep in your mind as you're trying to build arguments, not only at the systems level, but down at the direct service level when you're trying to partner with different types of organizations. From a policy perspective, I wanted to just put out this basic Venn diagram, that basically from this perspective, aspects of these various policy areas align pretty well. But because they're not traditionally aligned, a lot of effort needs to make this happen. For example, a state Medicaid director, maybe like Chuck, our previous speaker, maybe thinking about a whole host of things in the state Medicaid program, ED costs, managed care, duals, covering new lives, things like that. And a housing finance director may be thinking about redevelopment or affordable housing at 50% of the area median income, or compliance with various HUD regulations. And for the populations we tend to serve, those with the highest needs, these issues really converge at the center of these circles. At the system and direct service level, I think it's really where we need to focus our attention here if we want people to simultaneously live in integrated settings and get access to good coordinated health care. So these next few slides aren't necessarily an exhaustive list of strategies, given the time that we have, but they're strategies or issues that have stood out when I look at how states are approaching Olmstead and integrated healthcare. And many of these points are really applicable at all levels, the federal, state, and county levels. The first point is probably the most critical, that in order for good policy alignment, you really ultimately have to have the active involvement of your state housing and Medicaid and human services agencies, for instance, your state mental health agency. And when I mean active, I'm talking about not that we're just, working together or we were in a meeting once or twice, but it's really active engagement. And I'll break that down a little bit further. When I think about, from a community integration perspective, I'm going to break some of the slides down from a housing perspective and then a services perspective. And we're starting to get into some of the examples or strategies. The new revised HUD 811 program really is a mechanism that provides rental assistance out there to states. And the first round of awards that came out, 13 states were awarded, and that's a great program to take a look at going forward. And I think our next speaker, Dan, may speak a little bit about that as well. But the point I want to emphasize here is what's required in that program is that partnership, active partnership between the state Medicaid agency, the housing finance agency, and other human service agencies like the state mental health authority. That program really requires a formal partnership or interagency agreement that brings together those key partners that are going to make that housing and services component or alignment work for people. Another strategy that some states are starting to use, and I know Dan is going to reference this too, is an Olmstead preference. And the reference I put down at the bottom of the page is from HUD, but basically gives states the ability to offer a preference for specific target populations for people with disabilities to obtain housing within their communities. And it's a strategy that's starting to be used in Georgia and Illinois, and I know it's attractive to some other states as well. Bridge rental subsidies were alluded before, and that's definitely a strategy that when states are thinking about how to operationalize Olmstead, they're thinking about how are we going to get people access to housing. And whether that's new dollars or reinvested dollars, some states, actually many states in the country, are using some form of bridge rental assistance to support people going into communities. And then there's other system strategies from a housing perspective that states are looking at, particularly the use of low-income housing tax credits or other programs that are partnership ways to finance affordable housing for folks. From the services side, I won't go into it too much, but obviously from a strategy perspective, states are trying to think about what are the best strategies that we can use from a Medicaid perspective to finance services out there, and you've heard about those before. I think one of the key concepts to think about is what role then do state or county general funds also play in that mix? And I think that's where the art of, there are going to be some things that may not ultimately be covered by a Medicaid authority that may need to be used, you may need to use state or county general funds for. And the key aspect is how do you really work those two together? States are definitely looking from that high level, at programs like MFP or MFP-like strategies or balancing incentives. And when I say MFP-like strategies, it's really that concept of how do we reinvest funds or have money follow people into the community. And, there are some states, just as an example, who have statutes on the book that say if you close an institution, a state psychiatric hospital, or significantly downsize it, those funds need to be reallocated or reinvested in community-based services or housing, and those are things to take a look at. I also think what's really something for us to all consider going forward more and more is the role that managed care plays, obviously not only in healthcare, but what role it plays in supporting the community integration for folks with disabilities. And so, an example I put down here is, what Oregon's doing right now with its CCOs and really working in Olmstead performance indicators and data metrics into their CCO contracts and having incentives there. And I think that's something where the field really ultimately needs to think. And certainly at the strategy level, it's training. We're really talking about retraining or relearning our workforce out there, particularly in states where, frankly, the bias has been towards more institutional or more group home or supervised housing settings. And it's really training people more on those principles of integration and person-centered planning and things like that. Here's just a quick visual from somewhat of a housing first perspective that was alluded to earlier that really recognizes the importance of housing and building the behavioral health and other integrated healthcare supports around the individual. It's just a quick reference for you to take a look at. And here's another visual, and I think the key takeaway here is that because we're involving multiple systems, including behavioral health, Medicaid, managed care, housing, there must be clear role assignments among the parties at the system and down to the direct services level. There's no real one prescribed approach. I think that's relevant in any given state or system. Every system's going to have its unique approaches or culture or just the way they finance things. But the key is, if you're thinking about housing and services and trying to integrate people into the community, it's really being clear what each group's roles are or role assignments are in helping a person succeed or integrate into the community. So at the direct service level strategy, trying to break it down a little further, when I think about housing and on the housing side, I think about, what does it take for a person to succeed in their housing? And we're talking here really about tenancy support services. What are the services that, there's obviously, ADL training and things like that, which are down below, but we're talking about the things that are going to help a person succeed in their housing. And I tend to break these down into three phases or strategies: pre-tenancy supports, move-in supports, and ongoing tenancy supports. And so, for example, in pre-tenancy supports, we're talking about, what are the things that you're going to do with a consumer to help them contemplate moving into more integrated settings, helping them to think through or make the decision that they want to move into a more integrated setting, and then starting to get them in the process of getting their credit reports, starting to think about bank accounts, starting to prepare for actually going out and leasing an apartment or moving into an integrated setting. That next phase is really that move-in support or category, where the person's actually now transitioning into, their more integrated setting or their new integrated setting. Again, this could be coming from, a person who's already homeless and coming from the community side, or a person who's in an institutional setting moving into an apartment. It's all those things that are housing related, getting that person into the housing. And then there's those ongoing tenancy supports. And what I mean by that are, what are the things that, may pop up. So-and-so is not doing such a great job at not disturbing the peace at 12 o'clock on a Saturday morning. And who's going to really, maybe interact with the landlord? Who's the landlord going to call? What kind of supports are you going to need to help the person continue to pay their bills on time, keep their apartment clean, all those things that go into being a good tenant, living up to the terms and conditions that are in their lease agreement. And those are the housing-related supports. Underneath it are some more of the traditional-based services that we tend to think about, rehabilitative type services. For some individuals, it's a more treatment-based approach, like assertive community treatment, case management, care coordination, all of those things, peer-delivered supports that we think are important for people to have to really help them succeed in integrated community settings. And some people, depending on their level of needs, may need this full range of services that are there. One of the challenges is in states, and this is somewhat state intrinsic, is what is the lack of a better word, Medicaidability of many of these different services. And even from some of the questions that I've been seeing, states are in different places about what they're covering in terms of services for people who may be going out into integrated settings. And one just snippet on care coordination, I think, which is important. I think generally speaking, everybody likes the concept of care coordination, but I think we have to be real careful not to just to use it too loosely, because when you look at some of the studies about care coordination around the country, sometimes the results aren't so great. And I think what's important to do is really look at what care coordination models may be working around the country and really try to match that with the populations you're trying to serve. Okay. So going a little bit further in terms of some of the key services and supports that I see out there that are really important in states, from a housing-related perspective, who's going to do the referral and linkage into housing? These are things that you need to think about in your systems. States or jurisdictions are going to want to have roles like transition coordinators or relocation specialists, and sometimes those are buzzwords that you see more in Money Follows the Person programs, but the concepts are really key in terms of helping that person move through. A lot of places are looking at, funding one-time expenses associated with the move to or the preservation of community-based housing. And, in many respects, you can see some of these things covered through the Medicaid program, and that's a critical feature to really helping get a person established in their community-based housing. We talked a little bit about the landlord-property manager relations. Who's going to do that role? And the issue is making sure that role gets done, because that's a key function in terms of helping a person succeed in the community. And home visits. One of the things that we hear from folks is, well, John Doe is refusing services now, and now it's just a matter of time that he or she is kicked out of the apartment or evicted. And some providers or programs have really used a home visit model, which basically says, as a condition of tenancy, you obviously have the right to refuse services, but we also, from a housing perspective, reserve the right to come in and do a home visit to make sure that you're complying with the terms of the lease. From a services side, I think some of the key concepts, and I think this is reinforced by the recent home and community-based services rule, is that person-centered planning and choice perspective. That's something that you really have to see as a hallmark in your system and buy-in in your system if you really want to see people succeed. The services that are available really need to be flexible and intense as needed on a 24/7, 365-day-a-year basis. One point I think is important is, what a lot of systems strive to create assertive community treatment approaches in their system, and that's a really good goal because a lot of people can benefit from that treatment approach, but ACT can't be everywhere. And particularly when you think about some of the more rural or frontier states in the country, it just can't be everywhere, particularly if you want to have fidelity to the model. And so what's important is to really make sure that you can provide as intensive and flexible services that you can, maybe striving for an ACT-type level of approach, but recognizing that you can still probably meet people's needs in something that might be less than an ACT program, but more than case management. And so an example would be in New Jersey. When I was there, we had created what was called a residential intensive support team model, basically built on the supportive housing principles, fell short of a treatment model, but really took advantage of intensive case management and supportive housing principles and services. The role of crisis systems, obviously, Allison had mentioned before, is making sure that not only crisis systems are there, but they're oriented towards, I think, as much of a diversion model as they can be, to the extent that they can divert people back into the service system and away from the inpatient system, all the better. I think one important caution to put out there is against drive-by case management. One of the concerns that we see is that people with significant needs who are maybe coming out of institutions, for example, need a lot of services, and over time those may titrate down because that they're doing well in their system. But we want to be able to make sure that those services can titrate right back up as needed if the person's not doing so well. The concern is if we don't have those flexible systems and they're getting a minimum amount of case management, we're going to allow them to fall through the cracks, and we want to prevent that as much as we can. And then just back on that staff training concept, it's really critically important to make sure that we're including training for everybody out there. One of the things that we were working on in Louisiana in the development of their supportive housing program was the development of a training curriculum really around the principles of supportive housing so that staff could really understand what they were trying to accomplish and supporting people in the community. And then just finishing up on this last slide, again, just trying to break it down and give some more examples. Here are some approaches to consider. I'm not suggesting that any one of these approaches is a best practice or better than the others, because I think every state or jurisdiction is somewhat unique and has their own considerations to look at when they're developing their systems. But nonetheless, these are some things that are out there that when you're developing approaches to community integration or even integrated healthcare for that matter, you're going to want to take a look at. And so from a housing perspective, in Louisiana, the tenant services management piece, the piece that really is, getting people referred into housing and approved for housing waiting lists and things like that, is now performed by the managed care carve-out, and they're using a cross-disability approach. In other states like New Mexico or Pennsylvania, North Carolina, they're using a local lead agency concept, and they're designating local lead agencies in parts of the state to really be responsible for coordinating the access into housing. Another good strategy or approach to look at is, what are the relationships with state housing finance agencies? In North Carolina, for instance, they have the Targeting Key program, which is a partnership between the HFA and the Department of Health and Human Services, and it's similar in Pennsylvania with the DPW. And those are pretty strong relationships that have really resulted in a number of housing opportunities over the course of years. I referenced earlier the HUD 811 strategies to take a look at, and particularly the interagency partnership agreements. And I thought Texas has a really strong interagency partnership agreement that's worth taking a look at it, because it really clearly delineates the roles between the service providers and the housing finance agency. And that's actually up on the website at the Texas Department of Housing and Community Affairs. And then you should also take a look at what the various state housing finance agencies' qualified allocation plans have. And they're different, and they have different approaches in terms of how they want to produce housing, affordable housing for people with disabilities. And some of those QAPs set aside, caps on the number of people that can live together in a building, 10, 20, or 30%. They strive for meeting the very low-income individuals. They provide incentives for set-asides. And so the key point there is there are examples across the country of those partnerships between the housing finance agencies and the service agencies that really get towards developing as much housing as possible. And on the services piece, finally, I think it's important, a key concept is, and again, this is state unique. It's embedding key professionals in key teams and services. And that may look different in different places. In one state, it may be embedding some behavioral health professionals in FQHC settings. In another setting, it might be incorporating some, a nurse practitioner on some sort of community support service team. It's really trying to think about your system and how you can embed those key professionals in those spots. Peers and peer wellness coaching model, I think, is a great model when we're trying to support not only the community integration of individuals, but also their wellness and integration with primary health care. I think it's a great model to look at. There's a couple of states, New Jersey, Georgia, who've really gone after that model. I also think data collection and outcomes models that pertain to community integration and healthcare are really important. Oregon's doing some really innovative things there through their CCO model with DOJ. Definitely something to take a look at. And I think there's other things for you to take a look at in terms of what are the appropriate service referral and linkage roles. It's different. In some states, it may be state or government staff that are doing this. In other states, I think Chuck alluded it, the ADRCs or area agencies on aging may have a role in these areas. And for your state, you're going to want to look at, what are the options that we want to refer people into services from? often we think that people are coming from the service agency and we're trying to refer into housing, but sometimes they're coming from a different agency and they're looking for services and housing, and we want to take advantage of those. And just from a care coordination perspective, lastly, again, I want to just reinforce, try to find care coordination strategies that not only work for you, but that are likely to produce good outcomes. And, there's a couple of examples. The Camden Coalition of Healthcare Providers in Camden, New Jersey, Dr. Jeff Brenner was sort of the founder and lead of that, really narrowed down and focused on what its problem was. They were seeing a tremendous amount of ED use for people, not only with serious mental illness, but other disabilities coming through their EDs. And they came up with a care coordination model that took services right back out into people's living environments and really dramatically reduced their ED costs. And I think many of us have heard about some things, from the Missouri Health Homes model, again, that get at care coordination, really trying to reduce those costs for people with chronic conditions and co-occurring disabilities. And, when we don't address those things, they tend to be our more costly folks who end up in our deep end of the system. So I'm going to leave it at that and make sure that Dan has time.
Thank you very much, Kevin, and we'll move right along to Dan, please.
Thanks very much, Kevin, for your presentation and for all the work you do at TAC. It's a great website to go to as well because they're champions in this arena. I'm going to focus on the supply side of housing that can be available on a community integrated basis at a federal and state level. Having worked for the state of Illinois, my experience is 8 months dated, so I'll be, there may be some participants on the call who know more about that than I do at this time, but I'll cover some of the Illinois initiatives later. But first, wearing my HUD hat, I just want to highlight, we've talked about Section 811 repeatedly. I think it's important to understand that Kevin is being modest. The new Section 811 model, the Frank Melville Act, enacted in 2010 by a series of national advocates to totally restructure how 811 is structured from being a place-based program with 100% of the units set aside for persons with disabilities to a project rental assistance program to create opportunities for community integration. And so this is a program that only state housing finance agencies can apply for to obtain property-based rental assistance that can be allocated for up to 25% of the units in a particular development associated with the HFA. I think the key point to the 811 program is highlighted by Kevin, but I can't emphasize it enough, as I think the successful applicants in the first round likely were strong on two key points. One, having a really well-developed interagency agreement between their state agency service providers and their state housing finance agency, something that was really well thought out and where the services and the specificity of the roles are really detailed in a very specific way. I think that led to high scoring in that round of competition. I also think having a well-conceived referral network that will connect the target population that's identified in the application to the housing resources that will be made available is a critical component for success. Talking about the actual status of the what I'll call the Frank Melville portion of Section 811, because Section 811, it's important to be clear, exists as a legacy program. We have in our HUD portfolio hundreds of Section 811 developments, which are place-based and are 100% set aside for persons with disabilities, sometimes single disabilities and sometimes cross disabilities. These legacy projects are grandparented in under Olmstead guidance because of their pre-existing, often pre-existing Olmstead itself. But Frank Melville, named after a pioneer in the field, changes the structure. And so in fiscal year 12, HUD did a funding round of $98 million. It actually created approximately 3,500 units is the target to be created from that NOFA by the 13 successful state agencies that competed among 36 applicants. The cooperative agreements and implementation of that program are imminent. The successful applicants have been trained. It takes time to get a new program up and running, but I think we'll see the fruit of that first round of 811 in calendar year 14. Subsequently, Congress has funded 811 at $165 million, but we have to remember that's not to fund, purely speaking, the new rental assistance, but also to fund renewals of the legacy project. So what HUD has done is, between the FY13 and FY14 budgets, essentially assembled enough funding in the approximate amount of the original NOFA in FY12, plus or minus $100 million, that will go out in spring of 14, where either prior successful applicants or those who didn't apply previously or applied and fell short can come forward for Section 811 project rental assistance. So that NOFA should be out in the clearance and should come out in the next period of time in the spring of 2014. I now want to turn from the multifamily Section 811 program, which exists within the multifamily division of HUD, to public housing resources, which are a substantial contributor to the supply side of affordable housing under Olmstead. The coordinated remedial plan under what's critical about public housing resources is that the Department of Justice and HUD's Department of Civil Rights have enabled certain states, Georgia and Illinois in particular, who have a significant volume of either Department of Justice in the case of Georgia or guardian and advocacy claims from litigants. HUD has enabled in Illinois a coordinated remedial plan to be adopted that creates the ability for public housing authorities to create preferences in favor of Olmstead class members and money follows the person participants. The data upon which HUD relied in Illinois to authorize this plan and to grant prior civil rights approval in part was evidenced by the fact that 135 Olmstead class members of a class of about 33,000 were on the 80,000 person waiting list of the Chicago Housing Authority. An example of how this coordinated remedial plan has worked in practice is that the Housing Authority of Cook County, our second largest PHA, made a commitment to allocate 10% of its turnover vouchers, hard public housing units and project-based vouchers to Olmstead class members and MFP participants. They also made a specific allocation to the state's referral network of 100 non-elderly disabled vouchers that were available on turnover. And they've enabled 10% of their newly constructed permanent supportive housing developments that are not disability identified to be available to persons in Olmstead class or in the Money Follows the Person program. I want to highlight that HUD multifamily assets are potential assets for housing locators who are working to find housing for persons who are who have rights under Olmstead either through litigation or through any other means by virtue of being in long-term care and having the right to live in a least restrictive setting, that advocates should look at the HUD multifamily portfolio in several ways. One is that while HUD is largely identified with the project-based Section 8 program, we have a large portfolio of unassisted properties that don't have the huge waiting lists associated with the Section 8 program. And if one had a independent rental subsidy source, such as a bridge subsidy or a voucher, there is some, depending on your locality, room within the multifamily portfolio with short waiting lists or even vacancies. So contacting your local HUD multifamily division and engaging them is critical, because they may become helpful to you in urging owners to participate in an Olmstead initiative. Another multifamily initiative that is from 2013, I think that's critical in highlighting the point that Olmstead does not only relate to people already institutionalized, but as a preventive measure, is our HUD notice. It's not in the slide, 2013-21, available at HUD.gov. This is a notice that provides for preference in the HUD-assisted stock, both with Section 8 and without, for persons who are homeless to be referred to housing with waiting lists, and to do so through the means of a central referral network. And this means allows persons who are homeless and who could be subject to institutionalization in so many cases to access waiting lists that are otherwise closed to them, typically on a ratio basis, so many units to the existing waiting list and then a turnover unit to a person from a central referral system. Finally, within the HUD multifamily portfolio, this is hot off the press in a sense, and I don't know how huge it will be in significance, but I note in the omnibus appropriations bill the President signed Saturday that there is a demonstration program within the Section 202 program to test models of care to prevent nursing home enrollment by persons who are elderly. So people should look for that demonstration program. Turning to the state of Illinois, which has been, I think, path-breaking in its leadership, I can say not working for them anymore, and the IDA, the Illinois Housing Development Authority, has created a statewide referral network program, alluded to by Kevin. It sets aside, it doesn't set aside, but it grants high scoring priority for developers that create a set-aside of up to 20% of their units for referrals from the statewide network for members who are in an Olmstead class or in Money Follows the Person or who are homeless. The state also created a bond fund of $100 million in general obligation gap funding, the first time the state had ever made any housing available, any bond funding available. This is soft funding, not tax-exempt bonds with debt service, to create permanent supportive housing, a significant portion of which benefits persons that we're discussing today. Trying to move through this so that we can get to questions, I want to highlight that, as Kevin noted, states can take initiative to create their own programs of rental subsidy. In Illinois, our Division of Mental Health has created a bridge subsidy program that is very much a Section 8 lookalike program. It's both potentially on a voucher basis and also on a project basis. It's funded from a dedicated hospital tax, and about 1,000 people benefit from it and pay 30% of income, and their housing location is addressed on a housing first type model with service providers who help the bridge subsidy participants locate community integrated housing and then follow up with voluntary service provision through ACT and CST teams. We also have, through litigation settlements, created state appropriated funds for rental subsidy, and the state has a rental housing support program funded from a charge for the recordation of deeds. There's currently litigation challenging that program, but it is a model that we have had in place in Illinois, and under that program there has been preference for persons with disabilities provided by IDA again. And then I cite two websites for your reference when you get the slides relating to the PRA program. And HUD issued comprehensive guidance on Olmstead in about May of 2013 that incorporates by reference all the prior notices that Secretary Donovan has issued during his tenure, which are about 3 to 4, and they're incorporated in that one site that I give you at the end. So I'd highly recommend that to you because the Secretary has made Olmstead compliance and a paradigm shift in how HUD delivers housing subsidy a key priority. Thank you.
Thank you very much, Dan. I'm going to turn it right back to Jill so we can begin our question and answer period.
Thank you, Gretchen. We do have a few minutes for questions and answers, and I saw that many people were answering each other's questions as they scrolled by, and I've tried to group some of these into categories, and one of them relates to the practicalities of integrating Olmstead protected class members into mainstream housing that already exists. One of the questioners observed that many public housing or multifamily developments already serve a relatively high percentage of people with disabilities. Should those housing developments be considered as one of the resources that's available to serve people with disabilities, or are those not integrated housing now? I'm not sure who I should have answered that, but Dan, why don't you take the first crack at it?
Well, I would say, Jill, that the HUD portfolio is a vast array of housing opportunities. It's not uniform in its configuration, and we insure mortgages on properties that are integrated along income lines, and we insure market rate properties in central cities. We insure tax credit properties. So I would suggest that there are within the HUD portfolio some opportunities. I think what I'd like to say is that as a houser, and frankly not a person as deeply familiar with the service side of this critical equation, that this is all about putting puzzle pieces together, and not any one part of this solves the problem. I would highlight, though, that the HUD multifamily portfolio should be seen as a one piece of the puzzle, and I don't think that significant concentration is an issue unless we're looking at the existing 811 legacy properties to move somebody into. Then concentration would be an issue.
And this is Allison, and I can just briefly answer about the DOJ's Olmstead agreement. Our agreements lay out requirements for the states to expand supportive housing opportunities, and again, as I mentioned, they primarily focus on what new housing needs to look like, so in terms of units and expansion over time. The agreements do allow anyone who's part of the class to make an informed choice to live in housing other than scattered site supportive housing, but they have to be able to be offered that as a choice. So again, the approach has focused on both where to create new housing after we've gone in and looked at what exists in the system and where the gaps are, and that's really how the agreements lay out what the plan is for additional housing, and ensuring that people have at least an option and are offered a choice of living in scattered site housing if that is the most appropriate setting for them.
Well, Allison, that leads nicely into my next question, which is really where to find the resources for the expansion of affordable housing for people with disabilities. At a time when the ability to provide housing subsidies is challenged by federal budget issues, and if I understood the speakers correctly, Medicaid savings are not available to be used to pay for housing, where does the responsibility for providing permanent affordable housing to people with disabilities lie? Is the major resource for new housing development is the low-income housing tax credit administered by the states? Chuck, do you have a perspective on that? Is it really the tax credit to which people should be looking for expanding housing in response to the Olmstead mandate?
It's a tough issue. I will tell you one area where some of the advocates in Maryland are approaching us is if community-based services are less expensive than nursing homes, that even if to use some of those savings to the state to pay for housing. Let me give an illustration of what some of the advocate groups in Maryland say. If a nursing home costs $6,000 a month, and if community-based Medicaid costs $4,000 a month, kind of including all medical and social supports, therefore $2,000 are saved. $1,000 of that in Maryland, based on our Medicaid match rate, is state savings. So could the state set aside some portion of those state savings and subsidize housing, even if it's not Medicaid or Medicaid matched, even if it's just 100% state funded? And there is some conceptual clarity to that idea. It does raise the question of what are the true savings, apples to apples, between institutional care and community-based long-term services and supports. But I imagine that this is an area where there's going to be, more advocacy at the state level across the country. As let's not assume everything has to be Medicaid. If there are savings, some of those savings accrue to the state general fund, and can some portion of that be pulled aside as a housing fund? And not matched. So there are some other ideas. One of the other ideas that I'm part of a group working on is social impact bond investing in this area, also premised on the notion that it's less expensive to state and local governments to serve people in community settings than in institutions. But I think housing, I think the demand for affordable housing far exceeds what is available in terms of funds at the federal, state, and local levels, and I think that is, one of the major things one of the challenges we need to continue working on.
Kevin, you talked about the importance of the different kinds of services that need to be linked to housing, including housing tenancy supports. Can you talk a little bit about models for having housing providers and service providers working together, each understanding the other's expertise, and how do you draw the lines between housing tenancy supports and other kinds of services, and who really should do what when these partnerships are in operation?
Yeah, I mean, it's a hard conversation because, every state or jurisdiction is unique. I think you want to make sure that those principles are there, that, that there is some clear focus on, those specific housing tenancy supports. And like I had said, in some of those places, states have gone and used a local lead agency concept where they've designated a provider, or in some places, in Pennsylvania, for instance, it could be a county department of mental health services where they've assumed the responsibility of screening applicants, creating a waiting list, referring people into housing and things like that. In other areas, just by default, it could be down the ACT team itself bears the responsibility of not only providing the services but also trying to identify and link with the housing. I think the key concept there is recognizing that there's a very distinct skill set in terms of identifying housing, working with landlords, getting a person ready to sign and enter and comply with a lease. And so I think the point is it's not necessarily a one model fits all. It's really understanding, what those distinct roles are, and just making sure that the assignment of those responsibilities is clear. Because if you drop one of those from the equation, you're really jeopardizing a person's ability to succeed in their housing.
Allison, I saw some questions about the Olmstead protected class and how that relates to people recovering from substance abuse disorders. I gather, though, those such persons are covered by Olmstead. Is that indeed the case? And if so, what kind of practical implications does that have for the implementation of community-based housing?
So the ADA itself defines who is a person with a disability, and it excludes people who are currently using illegal drugs, but does cover people who are not currently using drugs and who are in recovery or had gone through recovery or rehabilitated in some kind of way. So people with substance use disorders have some coverage under any protection under the ADA. I think as we've been looking in our DOJ Olmstead agreements and looking at service systems and the kind of important supports that need to be there, we are making sure that services like ACT teams and crisis services have specialists and have the expertise of treating people with substance use disorders. And I know on the CMS side, they are also doing a lot to look around kind of new coverage in behavioral health services. So again, under the ADA, current users are not protected, but people who are former users and rehabilitation are protected by the ADA. And that's not just about Olmstead, but any piece of the ADA.
Allison, one further follow-up question that I think is for you. You talked in your slides. You talked about bridge housing or temporary housing before mainstream permanent affordable housing becomes available. Is that included in the CMS ruling that Medicaid dollars cannot be used for shelter?
Right.
Or is
so I want to be really clear what I was talking about. I was talking about bridge rental subsidies. So exactly the kind of concept that Chuck spoke about. It's incredibly common, at least in the states we've been in on the mental health side, to take state dollar cost savings. And again, particularly on the mental health side, where they may be paying 100% state dollars to serve someone in a state psychiatric facility at 3 or 4 times the cost of community services, half of which is reimbursed by Medicaid. And so a number of states, including Delaware, for example, I think Georgia has it, maybe New Jersey has also done it, has taken some of those state dollar cost savings, used it, just like Dan said, as it looks very similar to a Section 8 program, and then over time transition people into mainstream affordable housing programs to free up those state dollar bridge rental subsidies to use for another person that they're transitioning out of an institution.
If I could just jump in, it's Kevin. TAC is working on a document through the SAMHSA Olmstead Policy Academy on the different state bridge subsidy programs that we hope to have done in the next month or two. That would be available, to everyone. And it basically is taking a look at, what states have some type of bridge subsidy program, and generally, what are they looking like? What's the model look like, so that states who are interested in either revising theirs or creating one can see what's out there.
Well, we've come just about to 2 o'clock, and I want to thank the panelists for truly excellent presentations. I understand that an audio recording of this webinar is going to be available, and that the slides have already been made available. And on behalf of all of my colleagues at Abt Associates, I want to thank you for participating in the webinar. Thank you, everyone who participated in the webinar.